Welcome back to the equine anatomy course. We will continue this lecture on the anatomy of the equine neck, and we're going to follow the basic outlines that we've mentioned in the very first lecture of this topic. You have seen this slide before, the outlines for the lectures. We talked about the significance of the studying the anatomy of the equine neck. I mentioned a number of clinical cases that illustrates the relevance of this topic. Then we've talked about the muscles of the neck, a number of important muscles: omotransversalis, cladiomastoides, sternocephalicus, splenius, trapezius, rhomboideus, serratus ventralis, cervicus. We mentioned omohyoides, sternocephalicus, all of these muscles. And then I talked about the cervical fascia, mentioned that we have two of them. We have superficial fascia, which are loose connective tissue, and we have a deep fascia, which is regular, dense connective tissue. And the superficial one wraps around the muscles of the neck as well as the jugular groove. And we mentioned the borders for the jugular groove, how important that is for venipuncture and placing a catheter in the jugular vein. And we also mentioned that the structures that are protected by the deep fascia are carotid sheath, trachea, and esophagus. And I mentioned the importance, the clinical relevance for all of these structures. Now we move to the fourth point, and that is the lymphatics of the neck. And I mentioned that the lymphatics of the neck, or the lymph nodes that drain the neck, are divided into two parts. One is the superficial cervical lymph center and the deep cervical lymph center. And I mentioned that the deep cervical lymph center is or consists of three centers: cranial deep cervical lymph center, middle deep cervical lymph center, and caudal deep cervical lymph center. All these four drains the neck and part of the shoulder. Now we move to the fifth point, and that is the nuchal ligament. And I mentioned that that this particular structure is a very strong yellow connective tissue. The nuchal ligament supports the heavy head and neck of the horse and provides flexibility for continuous head and neck movement for grazing and moving. And the nuchal ligament consists of two parts: a cord-like structure, and a lamina type structure, a cord-like structure and the lamina type structure. We talked about that in the previous lecture. I mentioned where the funiculus nuchae originates from the back of the head, moves on the dorsal midline all the way and inserts on the spinous processes of the thoracic vertebra. And then the lamina part originates from the spinous processes of the first thoracic vertebra and also the funiculus nuchae, and inserts on the cervical processes, or the spinous processes, I should say, of the cervical vertebra C2 to C5. Now, other than the physiological importance of this structure, which is to support the heavy weight of the head and neck and to provide flexibility for the head and neck during continuous movement, for example, grazing. Other than this, there are clinical importances for this structure. And the clinical significance of this structure arises from the presence of a number of nuchal bursas associated with this with this structure. So let's talk about these the bursas. Now we have three nuchal bursas. Three nuchal bursas. We have the cranial nuchal bursa. We have the caudal nuchal bursa, and we have the supraspinous bursa. The supraspinous bursa. Cranial nuchal bursa, caudal nuchal bursa, and supraspinous bursa. We will talk about each of these bursas and the diseases associated with them. So first of all, we would like to see the location of these bursas. The location of these bursas. The cranial nuchal bursa. The cranial nuchal bursa is the space located between the ventral aspect of the funiculus nuchae and the dorsal aspect or the spinous process of the first cervical vertebra, the atlas. So the cranial nuchal bursa is the space between the ventral aspect of the funiculus nuchae and the spinous process of the first cervical vertebra or the atlas. The caudal nuchal bursa is the space between the ventral aspect of the funiculus nuchae or the cord-like part of the Nuchal ligament and the spinous process of the second cervical vertebra. The ventral aspect of the funiculus nuchae and the spinous process of the second cervical vertebra. The third bursa or the supraspinous bursa, indicated by the arrow in this picture, is located between the ventral aspect of the funiculus nuchae, and the spinous processes of T2 and T3, spinous processes of the thoracic vertebra 2 and 3. So the supraspinous bursa is the space located between the ventral aspect of the funiculus nuchae and the spinous processes of T2 and T3. Now, we want to know what are the diseases associated with these bursas. We have three diseases that are associated with the three nuchal bursas, cranial, caudal, and supraspinous. The disease of the cranial nuchal bursa between the ventral aspect of the funiculus nuchae and the spinous process of the atlas or the first cervical vertebra is called pole evil. Pole evil. The second disease, which is inconsistent because the caudal nuchal bursa is not present in all animals. It may or may not be present in some animals. The disease that occur in this bursa is called caudal nuchal bursitis. Caudal nuchal bursitis. And the third disease that affects the supraspinous bursa, which is the space between the ventral aspect of the funiculus nuchae and the spinous processes of T2 and T3, is called fistulus withers. Fistulus withers. And all of these diseases, if you will, are basically bacterial infections that caused by chronic irritation to that area, which basically allows bacteria to grow and pus to form in these bursas. So basically, these are pus formation diseases or areas. The bursas, physiologically, as you may or may not know, are basically areas that contain synovial fluid. And the synovial fluid is basically the 10W30, the lubricating a fluid for areas that continuously moving. To reduce the friction in those areas, the bursas are present. To reduce the friction, so the synovial fluid is basically to lubricate these continuously moving areas, to reduce arthritis. And so when these bursas are open, when there is an infection, that means that you have basically loss of this synovial fluid, arthritis, arthritic changes, and so on and so forth. So just keep this in mind, and you will study this in medicine in more details. Okay, so let's see pictures of those diseases. Pole evil and nuchal bursitis. We don't have a disease per se, unless the case was diagnosed and I said that it's not consistent. And we're going to see pictures of fistulous withers. These are two pictures showing pole evil, cranial nuchal bursitis, and you can see how the pus is being opened here. The wound, if you will, is being opened and pus is coming out, dirt and things like that. Same thing is here in the older picture to the left hand side. Caudal nuchal bursitis, as I mentioned, it's not consistent in all horses, but again, it's bacterial infection and pus formation, just like the other two diseases. This is a fistulous wether. Fistulous wether is basically again another pus accumulating area in horses, and that is a pretty that's a pretty important disease because it's caused by a bacteria called Brucella. Brucella causes abortion basically and sterility in both humans and in both animals and humans respectively, and so the key is that to for veterinarians and people who work with horses to be very, very careful about this disease, to handle it with care, to handle it with precautions, gloves, sterile gloves, everything, because they're at high risk, if you will, from getting infected. So this disease, brucellosis, can be transmitted to humans from horses, because the bacteria that causes this fistula swell is called brucella, which causes abortion in horses and sterility in humans. So these are the three diseases: Paul evil, caudal nuchal bursitis, and fistulous withers. Now we will talk about the last part of our talk, and that is the cervical vertebra. And here I'm just going to mention a few clinically relevant informations about the cervical vertebra. Uh, the most important thing is why should we study them? We study them because they're part of the vertebral column, which basically they may have arthritis, and they might have fractures, just like any other bone in the body. In addition, there is a very important landmark that we need to pay attention to, and that is called the Atlantooccipital space. The Atlantooccipital space is very important because we will utilize this space to basically uh, collect cerebrospinal fluid for neurological disease evaluations and other things that I will mention in a second. So this is a picture that shows the location of the Atlanto-occipital space, the Atlanto-occipital space, and it's very important to remember uh, the landmarks for this space. Um, this space is accessible cranial to the wings of the atlas on the dorsal midline. Cranial to the wings of the atlas on the dorsal midline. And usually when we used to do it, it's when we have to flex the head, so we can basically enlarge the space, so we can get more cerebrospinal fluid from there. Also, in addition to collecting cerebrospinal fluid, which is basically the fluid that's used to do neurological evaluation in cases of neurological diseases, we have to collect cerebrospinal fluid. This space can also be used to inject radio-opaque or radioactive mediums for myelograms and things like that, to basically show the depth of the spinal canal, if there's any stenosis, if there's any problems there. And I'll show you a case, wobblers, pretty common in equine medicine and surgery, that we can utilize this space to actually inject these radio-opaque and radioactive mediums in this space to basically see the depth of the vertebral canal, and to see if there's any compression on the spinal cord. I'll show you in a second. The third thing is you can actually inject anesthesia in this space, or intra-articular ultrasound guided treatments, also antibiotics and things like that. You can also perform arthroscopic procedures in this area. So there's a number of important points that we need to remember about the Atlanto-occipital space. So again, the landmark is very important. Cranial to the wings of the atlas on the dorsal midline. Cranial to the wings of the atlas on the dorsal midline, right where this needle is being inserted. And again, as I mentioned, usually flexing the head is a good idea to widen this area, to collect more, to put pressure so you can push some more fluid to get into the space and you can collect it basically. The same things that we've talked about, the neurological evaluation, aspiration of cerebrospinal fluid, injecting a radio-opaque material, injecting some medications, anesthesia, you name it. But the most important thing is to aspirate cerebrospinal fluid. for neurological evaluation, like this case here. This is a case for neurological evaluations. You know, you do a complete neurological exam all the way from gait analysis, from the way the horse looks and everything, and then after that, after you reach a a decent conclusion that okay, well maybe it's a neurological case, then the best part is to put the horse to sleep and actually do the collection of the cerebrospinal fluid from Atlantooccipital space. Again, the horse should be on the table. It's not gonna You're not gonna be able to do it in a tranquilized horse or in an awake horse. And this is just a sample to show you the different colors of fluids and where the cerebrospinal fluid fits. Usually it's in this color in general. That's where you would like your healthy animal to be. This is basically a saline control, and the others, they have a lot of blood, whether it's a man-made problem because of the person who did it punctured a small blood vessel that contaminated the sample, or sometimes it's not, there is blood actually in the cerebrospinal fluid. So you need to centrifuge that and see which is which basically. If you get a precipitate, that means this damage is basically pretty recent, so that means you made it. But if it's been there for a while, that means it is part of the fluid. That means there is leakage of blood into the cerebrospinal fluid. Things like that. This is just an example to show you. It has to be nice beer colored, clear things like these two colors, if you will. Now, let's talk about how am I gonna when I inject a radio opaque material in the Atlanto-occipital space. Again, remember the landmarks. This is what's important in anatomy. The landmark is cranial to the wings of the atlas on the dorsal midline. Cranial to the wings of the atlas. Cranial on the dorsal midline. I mentioned that we get cerebrospinal fluid, but also I mentioned that we can inject radio-opaque material to measure the depth of the spinal canal, and that's very important to measure if there's any stenosis or any compression being on the spinal cord that's causing the neurological signs on the animal. So you have so how we do that? This is basically a case of cervical stenosis myelopathy. We call it wobblers all the time, and it's a spinal ataxia. Basically, the horse is drunk, is walking like a drunk person, and it happens usually in thoroughbreds, the heavy breeds usually, uh, when and it's about 6 months to 3 years of age, and males usually are more affected with it. I'm just giving you synopsis of the case so you can have an idea, but you will study this in more details in medicine and surgery, equine medicine and surgery later. But this is just to show you wobbler and how we're going to utilize anatomy to basically understand the case. We have two options basically: the Bagby's basket, two treatment options: the Bagby's baskets and dorsal laminectomy, which basically fuses the cervical vertebrae together to reduce the compression on the spinal cord and reduce the neurological signs. But let's talk about uh, what can we do to diagnose the problem and how we can utilize anatomy to do that. So we need to do cervical vertebral column imaging, radiology, ultrasound, myelogram, and nuclear scintigraphy. And I'll mention to you nuclear scintigraphy in a second. But the myelogram is injecting a radio opaque material into the atlanto-occipital space to measure the depth of the spinal canal and to see if there's any compression. And I'll show you cases basically. So this is a radiograph showing uh, the we call it the intervertebral sagittal ratio. Intervertebral sagittal ratio. So we divide the depth of the spinal canal by the length of the vertebral body. A divided by B, and the number should be within the 52 to 57 range percent, 52 to 50% the ratio between them. If that ratio is different than 52 to 57 max, then we have a problem. I'll show you what I mean by that. But this is basically to show you how can I utilize the depth of the vertebral canal to diagnose a disease in the cervical vertebra. So I have to do the intervertebral sagittal ratio. Sagittal ratio is important. So for example, here we took two vertebrae together. So this is a normal one. So here consider this A and consider this B. A divided by B should be within the 52 to 57 range. However, when we come to a vertebra like this, which clearly it has severe arthritis and arthritic changes, we will see that this percentage is not the area between A and B is not 52 to 57%. It's way larger than that. It's within the 65s and the 70s. If you divide this by this arrow or the space or the distance here by the distance here, that's pretty important. We have to understand that there is a distraction there, and that means that the vertebra is really in bad shape. So that's how the sagittal ratio is being utilized. Same thing here. When we do, for example, a myelogram, this is a picture of the myelogram, and you can see clearly how the spinal cord is being compressed by this vertebra. It's being compressed, and so you automatically should think that because of this compression, we definitely have a problem with the neurological status of the horse. This is a clear neurological case because there is severe compression on the spinal cord right here by this vertebra. You can see the body of the vertebra is basically pressing. It's basically blocking all of the vertebral canal right here, and that's where the sagittal ratio also comes handy. So we have to remember the sagittal ratio. Okay. The last technique that I mentioned is basically the scintigraphy, and this is an image of a scintigraphy case that shows arthritis, and the way this technique works is basically you inject an radioactive iodine 125 basically, and radioisotope, if you will, and then the areas with inflammation will have high uptake, we call it. Again, you will study this in detail in large animal medicine and surgery and radiology later on, but this is just to show you that the areas of inflammation which has high blood supply, if you will, hyperemia, because this is one of the cardinal signs of inflammation, is hyperemia, increased blood supply, they have increased uptake of the radioisotope. And when we take an image, we can see that these increased uptake areas are basically the areas where you have the inflammation in the bones. This is the thoracic cavity. These are the ribs, and these are the thoracic vertebra. These are the lumbar vertebra right here. And you can see that we have a number of inflammations going on in the spinous processes of some of the thoracic, maybe the 8 thoracic vertebra, and also the second lumbar vertebra, spinous process, both the body and the spinous process of the second lumbar vertebra. So basically, this shows the the importance of the cervical vertebra and the importance of the Atlantooccipital space. The again cranial to the wings to the atlas, and on the dorsal midline. Dorsal midline, very, very important. On the dorsal midline, cranial to the wings to the atlas, dorsal midline, very important. Then we also talked about the sagittal ratio to measure if there's any compression on the spinal cord of these horses. So that brings us to the end of the topic of the equine um, anatomy of the neck. And next time we will go to the thoracic cavity to start discussing the anatomy of the thoracic cavity in the horse.